After that, alternative is the infrared coagulation, sclerotherapy. Grade 2, basic treatment is failure, rubber band. Alternative is the infrared coagulation, sclerotherapy. Grade 3, basic treatment and failure, hemorrhoidectomy. And can use the alternative to the step rubber band ligation. And grade 4 too. Grade 4, basic treatment, hemorrhoidectomy, and rubber band if the contraindication is operation. This for summary, we can see this diet for all of the grade, rubber band only until grade 3, sclerotherapy grade 2. Yeah. Okay. This dietary modification, we can see this the intake fiber more than 25 and 35 gram per day. More intake oral fluids, reduction consumption of fat, having regular exercise, improving anal hygiene, abstain reading in toilet, avoiding medication can make constipation and diarrhea. In the meta-analysis of hemorrhage symptom, fiber can reduce until 50%. This the medical therapy is oral flavonoid. Flavonoid is the very common flavonoids in the clinical is MPFF, sorry. Metallized flavonoid is we can treat can suggest the decrease bleeding 67%, persistent pain 65%, and reduce recurrent rate too. We can use this flavonoid can increase vascular tone and decrease capillary permeability, and as well, yeah, you can see the vein and lymph can improve. We can see this you can see the moment. You can see the meta-analysis about the MPFF. Yes, this MPFF was associated with the beneficial and statistical significant effect for discharge and leakage in the acute hemorrhageal disease. You can see this. And another two. And this another review for the MPFF. Can this the for long treatment very significant to reduce incident until 70% to compare the placebo number acute. When even the occur attack a shorter in time and the middle intensity in the MPFF, this is the RDM group placebo. This for the acute patient can relieve maybe only 45 hours. Yeah. Some even for 5 days until 100%. At the dose the 6 tablets for daily for day, and after that 4 tablets daily for 3 days. This is the same review. This for the maintenance. For maintenance, we can see 1 tablet daily 2 months. This on dose is 1,000, but if the dose tablet is 500, maybe twice daily. This the study in the Cipto Mangunkusumo Hospital, Jakarta in 2000. Study with the MPFF. M study is confirmed to efficacy and tolerability MPFF. Period is 8 weeks. We can see the before therapy. You can see the grade 3, grade T to 27%, grade 2 73%, and after that grade 3 post therapy, grade 3 70%, normal 30%, grade 1 is 63%. This is the reviews in American Journal 2014. If the medical management is non-effective after 6 and 8 weeks, so we have to do the perform like a rubber band, something like that step. This the non-surgical step. It injected sclerotherapy, rubber band, and the infrared coagulation. Yes, yeah. This infrared coagulation is the use a POW. Is each side the 3 hemorrhagic sites. But in Japan, there's a new sclerosan. Is the they call Alta, have been developed. It's Tanako. Is the can effective to grade 2, 3, even 4. Even 4. The sclerosan is placed the submucosal around the pedicle hemorrhoid junction. After that, the developing rectal mucus, prepuce mucus, the cushion, and the result, the local inflammation which eventually leads. This the comparison is POW and ALTA. We can see this the efficacy rate. POW is 20% and ALTA is 70%. This rubber band ligation is very second instrument is the rubber band ligation. Simple, quick, and we can see the first and second degree, some third degree. In the recent Dutch study, 90% surgeons is reported starting with the rubber band ligation, first treatment, to low the grade the hemorrhagic disease. Okay, we can see the instrument, rubber band, endoscopy in the rubber. For the beginning, we can suck the hemorrhoid. After that, hemorrhoid we can ligate it with the rubber, and finally, rubber have been ligated in the hemorrhoid. Is this the left side picture is before, the right side picture is after ligated. We can see the rubber. This infrared ligation, infrared coagulation. Yeah, and see this the best hemorrhoid through contact only between 1 until 1.5 second, but depending intensity and wavelength the coagulator too. Yeah, you can see the necrotic, yeah, white spot after procedure, and after that can make a fibrosis. This for the meta-analysis for the hemorrhoid, we can see the rubber band, hemorrhoidectomy, and the other, we can see the summary. Although hemorrhoidectomy more pain, more higher complication, and more time of work. So the patient certification accepting can do the time treatment modality seem to be similar. This for the effectiveness, rubber band ligation, compare injected sclerotherapy and infrared coagulation. You can see this, the rubber band ligation is more than effective than the other. But the complication is coagulation maybe more complicated, but the prolapse or relapse a little bit similar. Yeah, the bleeding, RBL only 80%, ERC 30%. Okay. So the last is the management hemorrhoid is based on the grade and qualification. Diet and lifestyle modification is first line to therapy or grade the hemorrhoid. MPFF show evidence improving overall symptoms hemorrhoid. And the last non-surgical treatment were invented and daily clinic to reduce the invasive based treatment. Okay, thank you.
Thank you, Dr.
Yeah.
Indra, for your information, your presentation. We move to the last presentation speaker, Dr. Wisnuwardana, with topic diagnosis and treatment of IBD, sponsored by Sanbe. Please, time is yours, Dr. Wisnu. Dr. Wisnu, can you hear me?
Thank you very much,
Please.
Dr. Jimmy. I will start my presentation. Okay. You see my presentation? Okay.
Okay, please continue. It's clear.
Okay, clear, yeah. To all of professor, my senior, all colleagues, in this session I will give about inflammatory bowel disease diagnosis and treatment. As we know, inflammatory bowel disease is a global disease. Prevalence increase in next decade. In 1 million people have IBD in United States, and prevalence is about 235 cases over 100,000 people. In the worldwide epidemiology of IBD is rapidly changing, increasing Crohn's disease and ulcerative colitis have been recorded in Asia, Africa, and Eastern Europe. This is review primary care workup of chronic diarrhea, report of ulcerative colitis and Crohn's disease, and discuss how to use immunosuppressant and discuss lifestyle change. This is overview of IBD. In the gastrointestinal and lower gastrointestinal is start from rectum until the ileum. Inflammatory bowel disease refers to chronic inflammatory disorder of gastrointestinal tract. It arises from inappropriate inflammatory response to intestinal microbes. The most common form of IBD includes ulcerative colitis and Crohn's disease. Ulcerative colitis involves the rectum and colon, where Crohn's disease involves any part of the wall of the gastrointestinal. Of the Crohn's disease, any segment of GI tract has involved from mouth to anus, have rectal sparing, discontinuous skip lesions with perianal disease like skin tags, fissures, fistulae. With transmural inflammation, the picture like stricture, fistula, perforation, and abscesses. In pathologic changes is epithelial non-caseating granulomas, chronic inflammation, infiltrate, and crypt architectural distortions. In ulcerative colitis, confined to colon, begins in rectum and extends in continuation to the upper, confined to mucosa and submucosa. Pathologic changes is cryptitis, crypt abscesses, crypt structural distortion, and lamina propria expansion with acute and chronic inflammatory cells. If the patient come to the primary care units, they have feel diarrhea over more than 2 weeks. Crohn's disease signs and symptoms starting from abdominal pain, GI bleeding, diarrhea, weight loss, fatigue, fever, joint pain, and skin rashes. We gave CD staging workup. First initial steps is laboratory, second colonoscopy, and then exam biopsy from the colon biopsy. If we find iron deficiency anemia exists and colonoscopy negative, we must perform esophageal gastroduodenoscopy. If AGN negative and setting of iron deficiency anemia, we must perform small bowel capsule endoscopy to consider imaging any of suspicion and narrowing structure in the colon. If abdominal septal present, we continue with CT and MRE to assess small bowel. In full scope endoscopy, mild disease, mucosal disease, we found moderate mucosal disease, and third with severe mucosal disease. As we know, disease activity, possible disease evolution over time is theoretical patient with Crohn's disease. Signs symptoms to inflammatory activity and bowel damage have increased by the time. In the study, sensitivity of CD-AOI, more than 150 detect endoscopically active disease, but was only 27%. Yeah. IBD is systemic inflammatory disorders have found in skin, eye, bones, and joints, kidney, and hepatobiliary. From the initial labs for Crohn's disease is complete blood count, CRP, erythrocyte sedimation rate, CMP, TSH, found antibody of strongyloides, consider Prometheus testing, and consider absorption laboratory. Absorption laboratories like studies of iron and ferritin, B12 of folic acid, vitamin D, vitamin A, and zinc. Stool testing with to found ovine parasites, Clostridium difficile toxin, Giardia antigen, Cryptosporidium, culture and sensitivity, and fecal calprotectin. Imaging with CT angiography to found small intestine disease activity, assess complication, abscess, fistula, and obstruction. High-risk patient, if have surgical resection with fistula stricture, abscess, early onset of disease, found in deep ulceration, perianal involvement, and severe rectal disease, and extensive anatomic involvement in Crohn's disease. Ulcerative colitis, sign and symptoms with bloody diarrhea, tenesmus, urgency, abdominal pain, fever, weight loss, joint pain, skin rash, and fatigue. Laboratory, complete blood count, CMP, CRL or ASR, fecal calprotectin, and stool studies to rule out of infection. Imaging only case by case if have basic clinical presentation. Because in imaging in ulcerative colitis, used to assess extent of disease and severity in severity flare. In Mayo scoring system, can take the assessment of disease activity, scores from 0 to 12. If the score is less than 2 is clinical remission, 3 until 4 mild activity, 6 until 10 moderate activity, and 11 until 12 is severe activity. Meyer scaling system with 10 variable of bowel movement frequency, rectal bleeding, endoscopy, and visual global assessment. In colonoscopy with endoscopic, Meyer score 0 if normal on active disease. Score 1 if mild disease with erythema, decreased vascular pattern, and mild friability. Score 2 if moderate disease with marked erythema, absent vascular pattern, and friability with erosion. And Mayo score 4 if severe disease is moderate signs plus spontaneous bleeding and ulceration. We count to IBD therapies. Goals of IBD therapies: number 1 is achieve mucosal healing and induce remission. Second, maintain steroid-free remission. 3, prevent, treat, and complication of disease. 4, avoid short and long-term toxicity of therapy. And 5, enhance quality of life. IBD therapy in the first time is use aminosalicylate of 5-ASA. Second, use of corticosteroids. 3, with immunomodulators like 6, mercaptopurine, azathioprine, and methotrexate. 5, with biologics treatment like anti-TNF, anti-integrin, anti-IL-12, and IL-23. As we know, azathioprine pharmacology is to push out purine synthesis and DNA RNA. Azathioprine pharmacology as active metabolite in score 235 under 400 is therapeutic range. If more than 400 is higher risk for bone marrow suppression. 6 mmP if more 5,700 is higher risk for hepatotoxicity. We know in 2019, use of biologic therapies inflammatory bowel disease with certolizumab, adalimumab, golimumab, and infliximab as TNF receptor, and anti-integrins with natalizumab and vedolizumab. In 2019, all of the pharmaceutical industry research about Janus kinase signal transducers with JAK inhibitor. The drug is tofacitinib, filgotinib, and upadacitinib as selective JAK1 inhibitor. Biologic therapy for IBD, as we know, certolizumab with the name Cimzia, adalimumab Humira, golimumab Symphony, infliximab Remicade, and anti-integrin antibody natalizumab is Tisabri, anti-antigribal antibody vedolizumab Entyvio, and anti-IL-12 and IL-22 antibody ustekinumab Stelara, used to moderate to severe Crohn's disease. Anti-TNF agents have immunogenicity, effervescence, and US to avoid if have infection, granulomatous like tuberculosis, listeria, viral and fungal, have autoimmunity, lymphoproliferative disease, neoplasm and skin and pediatric tumors, lesion psoriasis, worse are de novo congestive heart failure, hepatotoxicity, and debilitating disorders. Crohn's disease start from mild and moderate therapy, first if pentasa, and next step with biologic or theophylline with corticosteroid, third step with biologic theophylline corticosteroid, and fourth step with biologic therapy. Losing response of anti-TNF therapy, if we use increase anti-TNF dose on decreased dose interval, or swap another drug class with high ADA level single anti-TNF of swap drug class. And then if low ADA level, this is the no response of therapy. Sequential therapy for ulcerative colitis start from mild to severe. First with aminosalicylate, second aminosalicylate with theophylline and corticosteroid, third type biologic and theophylline and corticosteroid, and fourth colectomy with biologic treatment. Role of probiotics in IBD therapy. Probiotic investigated by on treatment of ulcerative colitis, paper by Cruz, found Escherichia coli strain. Then mesalazine drugs have 39–40% relapse compared to 30% of patients receive mesalazine. This conclude E. coli nasal was therapeutically equivalent to mesalazine to maintaining remission of acute attack of ulcerative colitis. And then Ishikawa et al. Test admitting fermented milk with bifidobacterium and lactobacillus strains, reported 73% remissions of ulcerative colitis, then 10% with non-supplement milk. In preliminary clinical data, suggested that probiotics may be effective in treating Crohn's disease symptom with Saccharomyces boulardii. Guidelines for initiating and follow-up immunosuppressive therapy with quantiferon chest X-ray acute hepatitis panel with annual head dermatology skin, sun precaution, annual pap smear, annual TB testing, and serum labs. And then for the IBD, has change of the lifestyle or lifestyle modification. First, with the diet Mediterranean, like primarily plant-based foods, replace butter, herbs, and spices, and limit of red meat. Other diets is eat smaller, more frequent meals, drink plenty of fluids, consider multivitamin dose, and go to dietitian. Start with probiotic, kefir once daily with bifidobacterium and lactobacilli, and then avoid dairy, gluten, and excessive caffeine. And lifestyle things, you must relieve or control stress management with exercise 20 minutes per day, relaxation breathing exercise with yoga and meditation, smoking cessation, avoid unnecessary antibiotic exposure, utilize patient education resources with CCFA. And final thoughts as a take-home message, we must take early diagnosis and avoid treatment delays. Second, treating IBD patient is a collaborative approach between primary care and gastrointestinal and other specialists. And number 3 is increase patient satisfaction. Thank you very much for your attention. Go back to Dr. Jimmy as moderator.
Thank you, Dr. Wisnu. Very good presentation. Now we enter to the discussion. We have several questions. For the first, to Prof. Ari, what is the preferred analgesic for acute pancreatitis patient, NSAID or opioid or other kinds? Please, Prof. Ari.
Yeah, thank you, Dr. Jimmy. So I mentioned that the analgesic is the important things. Yes, I think we must use what we call that the visual analog scale first. I mean, first it depends the condition of pain of our patients. You know, like and also we guide with the visual analog scale. Yeah, for me, sometimes we start with the NSAID first. I mean, if it doesn't work, so we give like morphine for the patient. So it depends the condition of the patient. But we must be careful, and because the conditions of stress of these patients, so you must give PPI also for your patients. You know, sometimes patient with the really pain, and there will be increase the acid, and also that's why. So you must combine NSAID, or maybe you want to give morphine, or with the PPI in our practice. And also most of the patients with the vomiting, so the vomiting will induce the reflux. So that's why we give PPI for this patient as well. So this is my answer, Dr. Jimmy.
Prof. Ari, how do you choose? You use NSAID and opioid.
I choose the NSAID first. So I choose the NSAID first. If it doesn't work, I give morphine.
Okay, thank you, Prof. Ari. The second question for Prof. Ari too. How the relationship between hypertriglyceridemia and acute pancreatitis from Dr. Andi Sainal, Pekanbaru. Relationship between hypertriglyceridemia and acute pancreatitis.
Oh yeah, that's right. Yeah, I mentioned that one of the predisposing factor of pancreatitis is hypertriglyceridemia. So that's why this is one of the pathophysiology that these conditions will induce the pancreatitis. So, but sometimes patients go to the chronic pancreatitis. So in daily practice, I mean, patients with the pain, and then we see that if the little bit increase of amylase or lipase, we check about the lipid profile of our patients, and if it is a high level of triglyceride, so we start to give anti-triglyceride for our patients.
Okay, thank you, Prof. Ari. Next question to Dr. Wisnu. How the role faces fecal calprotectin for screening IBD from Dr. Andi Sainal. How the rule faces fecal calprotectin for screening IBD.
Okay. Thank you for the question, Dr. Andi Sainal. As we know, from the inflammatory bowel disease, screening with fecal calprotectin is the use to see if the count of value is more than 50, and for high value, we must choose, if the symptom come with diarrhea is with IBD signs. If we have diarrhea more than 2 weeks and fecal calprotectin is positive more than 200, we found this is the specific this IBD diagnosis was performed. Thank you.
Dr. Wisnu, I want to ask you.
Yes.
How about your opinion about fecal calprotectin? Because fecal calprotectin only sign of inflammation, yeah.
Yes.
When you use fecal calprotectin for the patient with you suspect IBD, or sometimes you use for screening?
Yes. If we found no symptoms about tuberculosis or some of the Strongyloides parasites, and no science about the HIV symptoms, we use fecal calprotectin to screening the IBD. If the found have high value, this is IBD was performed. This is my answer, Dr. Jimmy.
Fecal calprotectin, do you use for evaluation of result for treatment? Do you use?
No, only for screening. Only for screening, yes. But remission is with science and remission about the symptoms of the patient. If we have treatment on 2 and 3 steps of the therapy of IBD.
Okay, thank you. Next question to Prof. Ari. How long we can give omega-3 infusion? It is safe for CKD, stage 5 or heart failure patient? Prof. Ari?
Yeah, first of all, I think we talk about the indication of parenteral nutrition first. So, I mean, if and also how much volume that we will give. Yeah, if the ask question about that, they will ask about the if we will give these parenteral nutritions to CKD or congestive heart failure. I think common things we must care about the numbers of volume that we'll give to our patients. This is the important things than using omega-3 or not, because you know the volume is the important things. The problem is we for CKD from chronic kidney disease stage 4, something like that, and then if the patients only the urine the volume urine only below 500, and also for patients with the congestive heart failure. So I think we must give the limited solution for our patients. This is the important things. But yeah, because the question is that if patients with the chronic kidney disease or congestive heart failure, for the important things, you must care about the how much solution they will give.
Thank you, Prof. Ari. Next question to Dr. Wisnu again.
Yes.
Dr. Angga, it's safe to
Yeah.
withdraw the immunosuppressant or biologic agent in IBD. If IBD is remission, it's safe withdrawal.
Okay. If the patient with IBD with treatment of the bowel involvement, we must evaluate if remission without pain and diarrhea. We must reduce of the drugs and see the response. If the response is good, we can stop the therapy and maintain with diet and the first drug of like 5-ESA to protect of the relapse of the IBD. This, Dr. Jimmy.
Okay, so we must continue treatment for maintain, yeah, maintain
Yes, maintain
remission,
with 5
not,
ESA.
not to
Yes.
stop the treatment, yeah.
Yes.
Okay, because there is no question again, I want to ask to My question to Dr. Indra. You mentioned before, if we fail to treat until 6 to 8 weeks, yeah, with
Okay.
the flavonoid NPPFF, yeah, in your institution, when you choose, if the patient like stage 3, yeah, stage 3, you choose rubber band ligation or infrared coagulation or injection sclerotherapy. Usually done, yeah, your institution.
Okay. Thank you, Dr. Jimmy. In the result and yeah, you have to choose the rubber band ligation because the complication is little bit uh, low. Hello?
Yeah,
Clear, Dr. Clear?
clear, please.
Yeah. I have a patient, more patient. There's a grade 3, and the patient don't want to operate, so uh, come to me, and I do perform the rubber band ligation. Then get treatment, but maybe take a long time because the range every month we have to rubber band ligation. Maybe depend on the size and depend on the how many hemorrhoid internal. Uh, yes, some people maybe 4 or 5 performs is okay. Rubber ventilation is more effective, Dr. Jimmy.
Okay. You have patient with complication like after 4 weeks, patient with the ulceration, yeah, ulceration.
With,
Well, how you manage if you have a complication like ulceration,
after band ligation,
urban ligation?
it's okay, no problem. You can after the maybe after we perform ligation, rubber ligation, maybe 5, maybe 7 days. Is the half the hemorrhage is broke off. After that, you can make the scar, bleeding, something. Yeah, depend on the maybe you have to avoid this hot, chilly, nose straining, something like that. And after that, recovery. Yeah, we give the for the maybe like asam tranexamic acid, something like that. Maybe if infection, we give the antibiotic, but very rare, very rare. Yeah. After that, maybe 2 weeks lah. 2 weeks is okay. After that, 2 weeks.
Okay, thank you. Maybe Prof. Ari can give maybe a message for our audience about this topic we discussed the last session. Prof. Ari?
Yeah, thank you. I think, first of all, I would like to say thank you to the all participants who asked some question to speakers, and also thank you for all speakers and moderators who support our symposium this morning. Thank you.
Thank you, Prof. Ari. So because all question already answered, so maybe the session we close and we give to the Dr. Saskia to lead the uh, session, yeah, next session maybe. But
Thank you.
I know the last session, yeah. Okay, Dr. Saskia, please.
Yeah. Thank you, Doc. Thank you to all speakers and moderators for the very insightful symposium. But now we're going to take photos first, Doctor. So please take a look at the camera, and I will count in 1, 2, 3. Okay, once more. 1, 2, 3. Okay, thank you very much to all professors and doctors. And also we would like to say thank you to our sponsors, Fresenius, Servier, and Sunbay. ladies and gentlemen, now we almost get to the end of the session, but before that, we would like to ask all participants to fill in our event survey. So the survey will be put on the chat room below. Be sure to put our to do our survey form, because your voice is so meaningful for us. Now, for all participants, please turn on your camera because we are going to take photos together for right now. So we are going to take several photos. Okay, we will still waiting. Okay, we will take photos now. I will count in 1, 2, 3. Okay, once more. 1, 2, 3. Okay, thank you very much. And this is finally the end of the virtual Congress today. Thank you for joining with us. And I hope this Congress will be very useful for us. And we will continue again the program on 30 January 2021 at 8:30 a.m. So thank you very much once again. See you, stay safe, and stay healthy. Assalamualaikum warahmatullahi wabarakatuh.
Thank you for all.
Thank you, Doc. Thank you, Prof.
Thank you, Saskia. Thank you, Prof.
Terima kasih.
Thank you, Prof. Ari.
Terima kasih, Dok. Terima kasih semua.
Prof. Jimmy. Oke.
Pak Yusuf, terima kasih nih CME. Supportnya.
Sampai ketemu tatap muka langsung ini. Soalnya cuma di virtual terus ini, Prof. Semoga cepat berlalu semua ini COVID.
Terdadang hadir terus nih, Terdadang. Makasih.
Oh iya.